And I would like to share with you all the things that have been changing in the last year. So no doubt treatment of AVM is something which is not easy. It's technically challenging already because the vessels we're dealing with are very small. We have to take small microcatheters. The understanding of AVM is also something that we all know is not easy. I mean, the reason why there is a so-called nidus is just because we're unable to properly define which are the vessels. And I think we should progressively shift from the so-called nidus to the venous segmentation. Another reason to be cautious, complications may be dramatic. We all know about this, and it's a rare disease, so it's not so easy to have often the ability to practice in doing this. And look around you, look what's going on in the world. There's a progressive shrinking of endovascular treatment of AVM because the cure that we expect to be very high is not so high. The cure is lower than expected because in small AVMs, maybe embolization can be done, but other treatments are very good too, and very often embolization is not required because large AVMs usually are anyway not treated unless there is a complication, which is today our most important recruitment, or mid-size AVM, which are probably today the main goal of embolization, are situations where embolization is just an adds-on to surgery or radiosurgery, but not the main treatment. And all those data are confirmed by Aruba that said, take care, embolization is not so good. But still, a lot of things are changing, and transvenous embolization is a game-changing technique. It changes the concept. It changes the concept so much that this is a curative treatment. And even for the deep AVMs, it's the best treatment. It's better than surgery. It's better than radiosurgery in deep AVMs that are otherwise hardly to be treated. But this does not mean that it's not at risk. And whenever there's a problem, as always with AVMs, it may be a very strong problem because in arterial embolization, whenever you don't get sure, security induces you to stop. If you go on by venous embolization, you cannot stop. If you do a partial treatment, it bleeds. So you must be very sure that you control everything. So I will not talk about the single-step procedure in small AVMs by transvenous because this has been said very often and we all know about this. So let's look at how this can evaluate. And today, one of the most frequent indications is to do stage venous after transarterial embolization. So look at this patient. She's young. She's 35 years old. She's a very nice, blonde, beautiful looking lady to one small child. And she just bled. And you see here the bleeding, the hematoma. She's still doing fine. And here is the angio, where you can see that there's something which is suspicious for an aneurysm. And indeed, as soon as we put a microcatheter in the lenticular striate, we see this here, which is obviously an aneurysm. I don't know exactly where it is, somewhere at the junction between artery and vein. But wherever the location, you have to treat it. And this is what I did. And we treated the aneurysm, but simultaneously I created ischemia because I could not prevent to occlude this. And she woke up with hemiparesis and she had some time to recover before we went on for further treatment. And this here is not good for arterial embolization. You cannot treat her properly. But if you look at the veins, this is now, that was the end of the first procedure. It's now beginning of the first transvenous. Look at here, the main vein, but this here is what I would call a primary vein. And this primary vein, you can access to it. Look at this, it's a bit narrow, but you can access to it here. And then you can place your microcatheter. This is what we did. And then you can place 2 microcatheters in order to control the length of the reflux, because the reflux cannot go in the main vein. You cannot accept this. You must be sure to control it. So we placed 2 catheters, did what I call the retrograde pressure cooker, so coils isoacryl, and then onyx, which enabled to occlude a significant part. And then we waited again for a couple of weeks or months. And this is second transvenous, where you may see here one big vein, but there's one other vein which is there, which you cannot see so well on this image. So we went to the superior one, did here again anti-reflux mechanism, and then this is what we occluded. And you see, after some time, most of it was done, but there still is a bit of vein. And this vein here was the one that was accessed, again, selectively control of reflux. And this was a way to cure. But cure is not what you can see at the time of embolization. Cure is if you wait some time. So we will wait 1 year to do the follow-up, and definitely on the follow-up, there is nothing, there is no AVM anymore. So stage or single transvenous after reduction by transarterial embolization is certainly a very frequent indication today, because you cannot go into a large AVM and pretend to cure the AVM in one step by the vein. This would be far too dangerous. There are too many shunts to occlude that you are sure to reach all shunts within one step. Second situation, only transvenous without transarterial embolization. Of course, you prefer to do transarterial because it's more easier, you can control. But what to do here? She's the wife of a colleague, a Japanese colleague that spent some time with us. And when he went back to Japan 1 year later, his wife bled from this deep ganglia AVM. And if you look, this is a posterior and anterior circulation. These are other parts. And if you put here the image of the posterior circulation, you can see the veins. You can see 1, 2, 3, and here 4 and 5. You must believe me that those veins could be isolated. So this was first treatment, making sure that you don't go further at this point. Then second transvenous, here is the catheter in the vein, so that after the whole anterior part was done. Number 3, you may see here the main vein, and this other here was a horizontal vein that we got access to here. Here we are with both catheters. This is what we occluded. And after step 3 of transvenous, this is the last transvenous procedure that we occluded this way. And she's cured. And we have also the follow-up. And the more we proceed, the more we're facing similar situation. I can show you exactly the same AVM. Now it's a 9-year-old boy. It's the same location, it's the same type. This is the posterior circulation. This is the anterior circulation. The main difference is that there is no straight sinus. Your best access to the vein is gone. And that's a really significant problem, because if you cannot get access to the vein, how to go here? First, I thought that this one could be good, but this is a cortical vein that makes here a double U-turn, goes around the temporal lobe to then go to the deep veins. It was not the good one. This was here the one we had to use. In first time, this is here a primary vein that you can get access to. We already have 2 catheters. These are the coils for pressure cooking. And this is the compartment we could get without having some reflux beyond this point. And this is the second transvenous. Here is the course that we needed to take. So this U-turn is always a pain. And here you can see quite well on this picture the vein that we preserved, the one that we access to. So the good thing here is this vein is long enough to control, to coil, and to isoacryl without getting beyond this point. So this is what we did. And this is here the retrograde injection of the different shunts. And now for the third transvenous, again, the same navigation through anastomosis, getting access to here. And you see that after third transvenous, the AVM is gone. but these are pictures. What we need to know is how is the patient, and here are some videos that his father sent to me after first, second, and third transembolization. You see he's always playing with the ball inside the room, so I don't know whether he could break the glass or not, but he seems to be doing on quite fine. Even after the third one, he had some significant paralysis, which was not due to ischemia, but to edema. And you can see here that the right side is not moving as well, but still it's quite okay. So next slide. Okay. I think that's an important tool that we're using now and that I would like to show to you today is the analysis of the venous segmentation when using not so much the 4D, maybe the 4D helps, but much more the fusion of different 3Ds. So this is what you can do when you're using a Siemens machine to do some rotation angiograms, to get some 3Ds, and then you can fuse both 3Ds. So this here, the 30-year-old patient, unruptured AVM. Yes, I treat unruptured AVM because Aruba is not the end of the game. With seizures resistant to therapy, increasing headaches, which is very often a functionally disabling factor. And here's the AVM. So anterior circulation, and now external, and now posterior circulation. And if you superimpose the venous phase of the posterior and anterior circulation, here is the anterior circulation. You see the main vein. And here is I go back, the posterior circulation, this one here. And look at this vein. Do you see this vein here? You just see it from the posterior circulation, not from the anterior circulation. You cannot see here. So if you look cautiously, this again, you have on the left side the venous phase from anterior circulation, and here's the venous phase from posterior circulation. And then you may see that this vein here is only to be seen when you inject the posterior circulation. This here is missing there. But you may look at this by doing the fusion of 3D. So here the MCA is gray and the PCA is yellow. And if you look at, so MCA gray, PCA yellow, we're looking at a yellow vein. And if you look at this here, yellow is posterior territory. And if we look at the posterior, you may see this vein here. You see where I put the arrow? And this is the main, the primary vein, which continues, and now joins the main outflow vein. So here you have the compartment for posterior circulation, here compartment for anterior circulation. You just want to treat the compartment from posterior. So this is the vein we're going to get. And now we have one microcatheter in the artery and two microcatheter in the vein. This is the vein we want to access to. The other goes to the main vein. You see exactly where the arrow is, where the bifurcation of both veins is, rather the fusion of both veins. So you know which is the point you must not go beyond. One vein here, the other one there. And then you can coil here. And then we added at some point some histoacryl. And this is a retrograde injection of a lot of onyx. And you see at this point, we already injected a lot. There is some doubt of stagnation of the vein. So you can always go to the artery to finish this. So we went to the artery, pressure cooker, and we finished that stuff. And if you look at this compartment that was treated mainly by the vein, this is the cast. This is the posterior circulation before and after transvenous. Before and after. Before, you can see the vein that enabled us access to all this, and after, this is gone. And same thing, anterior circulation before and after. So this is only transvenous, and this is a way to stage procedure, maybe shortly this year, the second step for this patient, where again, anterior circulation, posterior circulation, and here it may not be so easy to understand what is what. It's definitely difficult, but if you look at this movie, and I'm putting the movie on, You may see here you have a fusion of both sides. So I change colors now. Blue is posterior, yellow is anterior. And if you look at here, if we scroll, at some point we will see where this vein here arrives in the main one. And if you look at the course of this vein this way, you can look at it by the other analysis. Here, now I'm just changing the projection. This is now sagittal projection, and you see exactly where the vein arrives. So if you look now, according to what you see on 3D, you can find it on the angio. This is the vein you want to access to. So we went into this vein here. This one we got selectively. We put the catheter inside. We did a pressure cooker, here some coils, some retrograde injection. You see here the control from the artery. We still have this to occlude. So we continue to inject by the vein. It now goes retrogradely up to the arteries. This is the artery we could see before. So you can control exactly how far you go. And this is after step 2. So now we stopped at this level for this patient, and we're certainly going to continue, and I will show you in the next congresses evolution for this patient. So definitely transvenous embolization is a major evolution because there is much less ischemia. We do systematic MR, and you see that the risk of ischemia is by far lower when doing transvenous and transarterial embolization. So hemorrhagic risk today, in my experience, is 18 out of 376, so it's shortly below 5%, which does not mean that it's easier. Usually it's more difficult to navigate in the veins because the level of control is quite more poor, but you can solve most difficult AVMs that cannot be accessed surgically by combining both techniques that we've just been talking about. And in my opinion, the best way to analyze the venous segmentation is 6D, which would be a combination of 2 times 3D. And I think that should be done. I hope I was not too long. Thank you.